Welcome to Seniority Authority, the podcast where I track down experts to answer your questions on aging. I'm your host, Kathleen Toomey. Let's get smarter about growing older. We celebrate getting older on this podcast, but we're also clear-eyed and we want to make sure that we have a plan for what lies ahead. So what would you say if I told you I had a cheat sheet as to how to outsmart the healthcare system? And what if I said that cheat sheet or that guidebook was written by one of the most prominent gerontologists in the country? Sounds good, right? Well, stay tuned. He's right here. Welcome to Seniority Authority. I'm Kathleen Toomey, your host. For years, I've been looking for a physician who could share with me what the best way is to work with your primary care provider. Turns out my next guest was 10 steps ahead of me and had already written the book. Let me tell you a little bit about him. Dr. Mark Lachs is co-chief of the Division of Geriatrics and Palliative Medicine at the Weill Cornell Medical College, director of their Center for Aging Research and Clinical Care, and director of geriatrics for the New York Presbyterian Health System. He authored the book we're going to talk about, which is What Your Doctor Won't Tell You About Getting Older. Not only that, he took it a step further. He is co-founder of Compass Care, an innovative private duty companion care company that serves residents of Manhattan, Fairfield, Westchester, and Nassau County. Compass Care provides concierge non-medical care to older adults living at home, and a link to both Dr. Lachs' book and Compass Care is found in our show notes. Thanks to our show sponsor, the Riverwoods Group, Northern New England's largest family of not-for-profit continuing care retirement communities, where independent, active adults find purpose, community, and peace of mind. Visit us at riverwoodsgroup.org. Now, let's hear from today's guest. Dr. Lachs, I am so thrilled to have you on Seniority Authority. Welcome.
It is lovely to meet you, Kathleen Toomey.
Well, it's great because all of our listeners are generally very positive about getting older, and that's what we celebrate here. But we also know that getting older means you have to get smarter because things get more complex. Things break down and you have issues. So in the first chapter of the book that I read, you beautifully explained what a geriatrician is and what you strive to help people achieve in their lives. Can you talk to our listeners about the two elements that separate a geriatrician from other forms of medical practice?
Well, the most important really is the emphasis on function. The emphasis on function. You can have all kinds of diagnoses, Kathleen, heart disease, hearing loss, hypertension, arthritis, and I can't tell from those labels whether or not that person is in a nursing home or running a Fortune 500 company, because the world of medicine has effectively been taught to look at diagnoses. I'm interested in the whole person, which is the other centerpiece of geriatrics. And in the current age of medicine, you got a guy who looks at your right thumb and a guy who looks at your left thumb, and everybody thinks that's fabulous care. And in fact, as we age, that's not only awful care, that's dangerous care. When there is no conductor to the orchestra, older people and younger people really get into difficulty. It's just that older adults really are at higher risk because they don't have the reserve to withstand what really amounts to medical error or lack of coordination.
I love the image of a conductor because it is lots of different things going on in our bodies at once. And it's knowledge of knitting all of those together that is so important and sometimes missing. One important point that you make about the biology of aging is that there are things that we can do now to change or improve our functions later in life. As we talk about, this is all about functional medicine, about keeping you healthy and active and as good as you can be. Can you share with our listeners what a couple of those interventions are?
Well, it may surprise you because it's not a particular medication or a fancy treatment or a scan or a screening. I'm assuming that most of your audience has a primary care doctor who wags their finger at you to tell you to lose weight or exercise more or take this drug or get your colonoscopy. This is really about what we now call population health. It's things like socialization. It is things like physical activity, which we hear a lot about. It's things like purpose and meaning. Paying attention to those things has highly medically relevant benefits that really rival the things that I do in practice, like adjust your blood pressure medicine. So, for example, many of the seeds of ability or disability in late life are planted in our 30s, 40s, 50s. It wasn't long ago that we sat around and smoked cigarettes and ate lots of food and were overweight and didn't exercise. And the muscle loss, for example, that leads to falling as we get older, late life, really has its roots in sort of deconditioning that occurs much earlier. And the aging body, I'm going to save you a lot of medical school tuition now and tell you all about the first year of medical school. Basically, you'll learn that the good Lord gave us too many nerve cells, lung cells, heart cells, muscle cells. And over the course of a normal lifespan, even in the absence of disease, we lose some of that. Okay.
Mhm.
Now, 1,000 years ago, it didn't matter because you lived to age 20. Okay. And then you were felled by smallpox or a wild bull as a hunter gatherer.
As I said, a dinosaur. I would
Right,
never have
right.
survived.
And now it turns out you have to live to 80. Okay.
Mhm.
And that loss of function is now coming to haunt us. Okay. So the fact that you didn't walk in your 50s now makes you a faller, for example. Now, here's the great news. Small tweaks in, for example, physical activity, small tweaks. You don't have to swing for the fences. Okay. And really make a huge difference as to whether or not you can get yourself in and out of the bathtub at age 80 or 90. I mean, so you don't have to be a marathon runner. What I say often is, and you may have seen it in the book, Kathleen, it's like seeing an iceberg off in the distance. If you wait till you're in front of the iceberg, you got to turn the wheel real hard to miss the iceberg. But if you're a few miles away, you just turn the wheel a little, and by the time you get to the iceberg, you miss the iceberg. So that's the metaphor that I like. And that's true about the way we interact with other people. I mean, who would have thought that loneliness would have gotten the attention it has gotten? You heard our Surgeon General recently, right? Talking about
Mhm.
loneliness starting in early life. In England, you may or may not be aware, there is a ministry of loneliness.
I do know that,
Yeah.
and that's way ahead of us.
Yeah. And loneliness is as bad as any disease I see in my practice. It affects your other diseases. When you're lonely, you don't take your heart disease medicine, you don't eat properly, you may become depressed, and you get sick. So it turns out, shockingly, that the mind and the body are connected. And it's not just tree hugging anymore. There's real science to support these really paramedical, non-medical things that, along with good primary care, can make your life better. Not just longer, but better.
Yes, that's exactly it. It's not necessarily longevity that we're talking about, but it's quality. And what I love, and we talk a lot about this on the podcast, is changes you make now. So steering that ship away from the iceberg now. And again, just exercising, just 30 minutes, going for a walk, not necessarily having to do the marathon, but all these things you can do now that will help improve your bone density, because that's a fact that you can improve your bone density starting at age 60. If you've never lifted weights, you can lift weights and make that difference. And the social connection is so critical. I think we all learned that lesson during COVID, but it's just as hard if you haven't started the practice of connecting with people as you get older. You stop driving, you stop going out, you get more homebound. You have to work harder at it.
COVID was an amazing natural experiment that proved all the things we knew. There are a number of studies. I mean, there's so many of them. They looked at nursing homes where visitation was curtailed because of COVID, right? And in nursing homes where there was not a single case of COVID, the weight loss equal or exceeded the weight loss in COVID affected nursing homes. And it's because there was no socialization. There were no congregate meals. I mean, isn't that amazing?
Yeah.
And I had many patients who died during COVID without COVID. They became isolated, depressed, deconditioned. They couldn't exercise. So this is real stuff. I think health insurers are starting to look at it. Physicians are starting to look at it. And what's great about it is it's not like this is toxic chemotherapy we're talking about. This is healthy stuff. The problem is that everybody wants a pill,
Oh, yeah. Oh, yeah.
and darn it, doctors are willing to give them to you. No better way to keep the line moving in a crowded office than to give someone a prescription. We can talk about that too. It's interesting. Often patients feel sort of ripped off if they don't leave the office with a prescription. And I had one say something like that to me. I got my pad out and I said, 10 knee deep bends a day. And I handed them the prescription.
Good. That is the way to do it, is for physicians. And we've talked about this, physicians to write prescriptions for exercise, write prescriptions for go meet a friend for coffee once a week. Because I am a naturally optimistic person. And I feel like this generation of people, boomers and up, are a little bit more aware of the connection between the mind body and a little bit more proactive in terms of managing their own health. And I want to believe that people are interested in lifestyle solutions, not just pill solutions, because I feel for physicians, they're in a tough position. I have my 90-year-old parents want a pill for everything. And, when you're up to 20 medications a day, another pill is not the answer.
Another pill is the problem. There's a whole movement in aging called deprescribing that we can sort of talk about at some point, or maybe in another podcast. But every Monday morning, I spend a half an hour convincing someone that the medication they saw advertised on television last night is not for them. Where I could have spent that time going over their exercise routine, their diet, their socialization, making specific recommendations about clubs to join, those kinds of things. And I like to say motion is lotion.
That is absolutely true. Motion is lotion. I'm going to add to your prescription card, Dr. Lachs. I would say when you write the prescription for 10 deep knee bends, say, turn off the news after an hour. Because I see this in older adults. We're spending more time on these 24-hour news channels, and advertisers are smart and they're putting money into all these medications, and you are just getting brainwashed. So only watch the news for an hour. That's what I would love.
The late comedian Norm Macdonald, who I liked, he does a whole bit about this. And he says, when I was a young man, the news was about a half an hour. And it turns out that was about right.
It's true. It is true. We don't need that much. But let's talk about your PCP, your physician. This is one of my favorite chapters in your book, because I think one struggle that some of our listeners experience is that physician that says, your back hurts. What do you expect? You're 80 years old. So we don't want somebody who's going to just fluff everything off as a sign of aging and say, suck it up, buttercup. We also want somebody that is realistic in terms of what someone who's 80, who's got a back problem, can expect. How do you navigate? You have some really good recommendations in that chapter. Can you share those?
That chapter begins with one of my favorite jokes, which you probably saw, which is Morris, who goes to the doctor and he says, my right knee hurts. And he says, how old are you? He says, I'm 95. And he says, well, what do you expect at your age? Right. And then Morris gets up and sort of very angrily says, the problem with that, doc, is my left knee is 95 and it doesn't hurt at all.
Exactly. I love that. I love that.
That joke conveys a very serious idea about ageism in healthcare, that every medical problem as we get older is a function of aging. And what a terrible message to older people, that this is getting old. Now, look, there are certain problems that, aging is on average the greatest risk factor for the onset of chronic illness. There's no doubt about it.
Yeah.
However, my job is to make you live well in the face of inevitable chronic medical problems. That's perfectly fine. So what the message I try to convey to patients is that, look, I'm going to look into this. I'm not going to assume that I'm going to examine your knee. I'm going to look at your labs. I may x-ray your knee if necessary. I may prescribe physical therapy. And then at the end of that, if you still have knee pain, we're going to treat that also. But it's only then that I'm willing to ascribe whatever your symptom is to aging. Okay. I'm going to take this really, really seriously. Now, look, that takes time. And if you get to the office at a Medicare Advantage plan, or it's 2 minutes with the foot or the ear, or whatever the thing is that day, I think Medicare Advantage, the source of another podcast probably, has potential to have people spend more time with patients and also pay for things like socialization and exercise classes. I mean, the world is going in that direction. But I think patients need to be advocates and to say, explain to me why you think this is aging and not of the arthritis I've had in my other knee or things like that. And it's very interesting. It's amazing how powerful, articulate, advocating people clam up at the doctor's office. It's sort of interesting. This way you're a mechanic, Kathleen, over some part your car needed, okay? You would be livid. I don't know if it's a cultural issue. My oldest old patients have just inappropriate reverence for their physicians and are just
I've never heard it we referred to as inappropriate reverence. I totally get what you mean, but it's like, you are the doctor. You are the answer to my problems.
Listen to this, newsflash. Turns out that doctors are human and they make mistakes and they rush. And so I'll tell you though, their adult children have no problems asking lots of questions and demanding, So you need to be an advocate. There's a way to do that as an engaged partner as opposed to being sort of an obnoxious Mack truck. So that's one way of handling it. The other thing is I'm a big fan of the list to come prepared. You wouldn't go to your hairdresser, your accountant, your lawyer without some plan about what's going to happen in that interaction for however much you're paying per hour. And I do encourage people to have a list, but I'm a big fan of the 3 things. You're allowed 3 things because if you come with 100 things, nothing will get done. And if people don't have a list, I will make them articulate 3 things, particularly in a first visit. Look, we're meeting for the first time. There's a lot to digest. You've told me so many things that are problematic. You have a child who's got autism, an adult child, and you have this cholesterol problem, your hip hurts, you're having sleep difficulty. I can't do everything all at once, but if I can name 3 things in order, what would you like me to work on and focus on? And it just makes it better for you and it makes it better for the doctor. And then it might be a different 3 things the second time, particularly because thing 1 and thing 2 might have gotten better. So just organization around the primary care visit, you need to prepare.
That is fabulous advice. Fabulous advice. So listeners, when you are going into the doctor, your physician, your PCP, have that priority list of 3, because as we know, and as when you will read Dr. Lachs' books, every physician has what they call a panel of about 2,000 patients. So it's a lot of people to keep track of and a lot of labs to read, et cetera. So if you come in and say, these are my most 3 pressing things, and then keep that list and then follow up on the next, do whatever the recommendation is, and then follow the next. I love that. I think that's very good. What would you say if one of the listeners was experiencing a conversation with a practitioner who said, it's just because you're old? What do you do there? Do you get a new physician? Do you say, I disagree, or I think this could be resolved differently? How would you respond to that?
It depends where you are in the interaction and the relationship. I mean, if this is a long-standing relationship, people say, where do I find a geriatrician? There are about 5,000 of us, and the number may actually be dropping as the first cohort retires.
We know there's not enough geriatricians.
There's not enough, and it's problematic. Yeah. And so invariably, aging care is provided by primary care internists and family practitioners. If you find a gero-friendly primary care doctor, I would hang on for dear life. So someone you've had a long-standing relationship with and who knows you and your family, I think that's like irreplaceable.
Yeah.
And if you could very politely and say, look, I know you a long time. I don't think you're right. You could ask for a second opinion. I love when patients ask for a second opinion. Many patients think physicians will be offended. I'm like, maybe I'll learn something too. Go see the arthritis specialist or the rheumatologist. So, I mean, that's another way to handle it. Doc, I don't think this is aging. I mean, I think my hearing loss or my vision problem or my knee pain, is there someone else you could refer me to? Now, look, if it becomes chronic and ongoing, time to vote with your feet. And we can talk about how to find a good primary care doctor. Geriatricians tend to aggregate around academic health centers if you're lucky enough to be near one, but that's not true for a majority of us. The American Geriatric Society has a website that can sort of ferret that out for you. It's in the book. Yep.
Great. Let's go there. If our listeners are all over the country, if some of them are not in areas with an academic center or there are no geriatricians in their area, are there questions you would recommend when interviewing for a new practitioner when you are older?
Well, access, so understanding the nature of the practice and how it works. If I need to be seen the same day, when do you return calls? Do you have a paraprofessional staff? We should talk for a minute about nurse practitioners that survive without nurse practitioners.
Yeah.
Much of the medicine and geriatrics I have learned is from nurse practitioners.
Yeah.
And we in geriatrics don't have a procedure like the GI doctors have their colonoscopies and the cardiologists do their casts. And I like to say that our procedure is team. Older adults have all kinds of different issues that are historically not what's taught in medical school. I know a lot of podiatry. I know a lot of psychology. I know a lot of audiology. More so, that's part of the training. Many of my patients won't go see a psychiatrist. They find it stigmatizing. So I do a good deal of that. So I could not survive without nurse practitioners. And by the way, a good nurse practitioner. And it's very interesting. I have a nurse practitioner who's about to retire. I don't know what I'm going to do. After a while, they don't want to see me. They want to see Mary. And it's so interesting because here in the city, I'm in New York, people feel incredibly important because they got an appointment with a cardiologist on Park Avenue. That person may have 40 years less experience than my nurse practitioner and 5 minutes to spend with them, and she has an hour. This is all about time, Kathleen, in terms of what I'm describing to you is a relatively time-consuming activity. I love it. And the issue becomes really for the healthcare system, how to finance it. Things are coming down the pike where we're beginning to realize that spending that time prevents a hip fracture, prevents a cardiovascular event, prevents a hospitalization, and saves the health system money. So there are ways that I'm hopeful that the goals of care can be aligned with the goals of finance to really sort of to do this. But you need to vote with your feet if you can't reconcile this, and you need to see who else is available in a practice. And in academic practices, there's often a social worker, a nurse practitioner. There might be decent physical therapy. There might be mental health services. Again, COVID taught us that the whole world is anxious.
Absolutely.
And you cannot care for people without tending to mental health needs. You cannot be in it. So I feel very, very strongly about that.
If you're getting smarter, let us know. Leave us a review, a rating, wherever you listen to podcasts. Tell your friends and follow us on social. We're at Seniority Authority on Facebook, Twitter, Instagram, TikTok, and YouTube. And don't forget, if you're listening to YouTube, hit the notification bell so you can subscribe. Or subscribe to our newsletter at seniorityauthority.org so you don't miss a thing. So what I'm taking away from this is understand how the practice works, and time is critical, and understand that this practice that you are interviewing is going to look at the whole person and include preventative, positive practices, not just reactive, and that you may also need a psychiatrist and an audiologist and a podiatrist, but getting someone who can really understand who you are, where you are in your life. As you said at the top of the show, you could be 80 and running a Fortune 500 company, or 80 and needing skilled nursing help. It all depends on where you are in your journey. 80 doesn't tell you much about your functional capability. And I think older adults are tougher adults because as you get older, you have the propensity for more of these chronic illnesses. And so you've got to work harder to stay healthy.
We have many sayings in geriatrics. Are you seen one 80-year-old? You seen one 80-year-old?
Yeah.
Right? I want to just use the word prevention in your last colloquy, and I just want to build on that. So I think what comes to mind for most people when they hear the word prevention is flu shots and colonoscopy and all kinds of screening. Yes. But prevention in my world is prevention of falling, prevention of loneliness. We have a house call program, which is kind of fun because I sneak around and look in the medicine cabinet and see if there's rotten food in the refrigerator. But I also look at things like the lighting and the stairwells and the rugs. And so that's preventative medicine as far as I'm concerned, right? That's a good example of how holistic care helps you to live better and helps you to live longer. So I like what you said about prevention. I just wanted to build on that idea. It's not just your flu shot and your pap smear.
And thank you for clarifying, because I wasn't thinking about those at all. When I was thinking prevention, I'm thinking get outside if you can every day, walk if you can every day, stay socially connected every day, We know that these practices have a direct impact on your body, on your health. And it's not all woo woo kind of flaky. It's real. And COVID taught us that. So I think it really helped. The silver lining of COVID was to help people understand the need for connection is so hardwired into our bodies that it affects our health if we are starved of connection.
And it also highly, to a large extent, destigmatized mental health care, which was really one of the, but still too stigmatized, Kathleen, but what a fabulous development that was.
Yeah, that was really, really good. One of the things that you talked about, one of the words that I had never heard before I read your book, which I totally get, is the word hospitalitis.
Yeah.
Can you explain what you mean by that and why that's important as older adults?
Yeah. Well, simply put, the hospital is no place for sick people. It's so interesting. I'll get a call once a month saying my mom is doing poorly. If you could just put her in the hospital, she'd be so much safer. No, it's the most dangerous place for older people, rivaled only by the emergency department, by the way. And so there's been a gajillion studies now that when older people go to the hospital, they become sick aside from the reason they went to the hospital. They suffer confusion called delirium. There's a whole chapter about that. They fall. They get unnecessary medications. They're not ambulated. The first order physicians often write when you come to a hospital is bed rest. Bed rest is the worst. Things in motion stay in motion. And you know what happens to things that aren't in motion? And the reason, Kathleen, is that hospitals were developed 150 years ago for people who are probably on average age 25. And now they are populated. You've been to a hospital recently? It is basically,
yes,
in 5 or 10 years, hospitals will have people who gave birth that day, people who had major trauma, and everybody else is going to be old people. Because very often there's no choice but to hospitalize somebody. When that happens, that needs to be as brief as possible. And there too, I say geriatrics is stuff that your grandmother could teach you. We've learned that we can prevent confusion in the hospital by things like bringing your hearing aids and your glasses.
Absolutely. Bringing your list. Yes.
Making sure that the meal in front of you is fed to you. But we do things like in the emergency room, no visitors. No visitors. My God. And this relates back to your question about the practice, which is how do I avoid the emergency department, which is good primary care, the ability to get to someone before Friday night with your cough before we find out it's pneumonia. So bad things happen in the hospital, not because we're mean, but because it's a place that is fraught with dangers. There's a whole movement now that you may or may not have heard of called age-friendly healthcare systems. You might want to interview some folks from the Hartford Foundation about how, not just in the hospital, we're trying to make health systems age-friendly. Fonts that you read in your patient portal. Doors that can't be opened because of the amount of force that it requires for an 80-year-old. Registrars that you can't hear their voices. And basically, the most important thing is what matters. So the healthcare system is often focused on the cholesterol or some other test, and that's not what matters to the patient. And when I say to patients, and I always ask, what matters to you? I want to be able to lift my grandchild. Not that my cholesterol is 213. Okay, I don't get that. I want to be able to go to the book club. I want to be able to travel. I want to be able to get a few blocks without getting breathless. That to me, why did you become a doctor? It's to treat that. And the great irony of this, Kathleen, is that 150 years ago, you were on the farm and you went to see the local practitioner. This is what he did. There was no technology or blood test to distract you from what we call the chief complaint, right?
Yeah, I never thought of it that way. But no CAT scan machine.
It hurts here. I have a cough. What's this rash? Don't get me wrong. The technology is amazing and wonderful, but it takes our eye off the ball. The ball is the patient, right? And the key is combining the art and the science. And there's just simply no substitute for understanding a patient and their family over a long period of time, which is why I said if you can hang on to your primary care physician, despite inevitable differences at time, I would hang on for dear life.
And that's why you always want a physician who's younger than you are, because you want them to not retire before you don't need them anymore.
I had a colleague want to refer a patient. We have a huge patient waiting list because we take Medicare. And this retired psychiatrist wanted a doctor. And I assigned her to one of my very junior doctors who I would let take care of any member of my family. Interpersonally and scientifically and clinically fabulous. And she said, I want a senior doctor. This is a medical person. In my head, I said, you're a fool. You know?
Yeah. Yeah.
These are people at the top of their game who will live a long time and come to know you. And that's a physician.
So that's ageism in the opposite, where they want somebody,
Exactly right.
they don't want someone younger, they want someone older.
That's right.
And what you're talking about is exactly what Atul Gawande talks about in Being Mortal, is understanding what is important to you as the person and then helping you achieve it. Not test after test after test, but how do I help you live your life in a meaningful way? And that's different for each person. And I want to get to help, to the set of recommendations you mentioned in your book called HELP, instead of going to the hospital.
And so HELP stands for the Hospital Elder Life Program. It was created by a dear friend named Sharon Inouye. We trained together at Yale. She now runs the Harvard Aging Brain Institute. And she's done a remarkable series of studies looking at what we call delirium in the hospital. Prevalence of confusion in the hospital in people over age 85 is probably 50%. I mean,
Absolutely.
If you've seen it, and you probably have, it is incredibly upsetting to families and patients. And it's preventable with a series of interventions like ambulating the person, engaging them in Sudoku, making sure their sleep-wake cycle isn't disrupted. And much of it is medical, conducted by the medical team, but much of it can be conducted by family members. Mm-hmm. So bringing pictures of children and grandchildren, creating a familiar environment, making sure that your glasses and your hearing aids are available, favorite books and tchotchkes, those kinds of things. And she's shown that these kinds of interventions reduce the rates of confusion and subsequent even mortality. The technical elements of a hospitalization, the surgery or the chemotherapy, almost invariably they go perfectly. It's the other stuff. Being woken up at 4 a.m. for a blood pressure that you don't need to have taken, right? Being given an unnecessary sleep medication. Orders for bed rest and not getting up. You get a bed sore, then you get up and you're dizzy all of a sudden. So it's the little things. You know, what I say about primary care, geriatrics, and aging, and inpatient as well, given the choice between the valedictorian of the medical school class and the guy who's in the middle, but who has obsessive compulsive disorder, is willing to roll up his or her sleeves and get in there and look at the records and what the consultant said and who prescribed this drug, I will take the second guy or gal every time.
Yeah.
I might even take the guy at the back of the class if he did that. You know that joke, right?
No.
What do they call the person who graduates last in his medical school class?
A doctor?
Correct.
I love that. I love that. You made it through. This is not an easy walk in the park going to medical school. So
the other joke is, as we avoid medical care and hospitalization, now we're getting to tests, is because we do too many tests. The same way we give too many drugs. My late father used to say the definition of minor surgery on somebody else.
I love that. Yeah. So, surgery is huge. Hospitalizations are huge. We don't want to do it unless it's absolutely necessary. And you want to get out of the hospital as fast as you can.
Right, right. And so the other thing I want to talk about is testing, and specifically overtest. Mm-hmm. You'll hear commercials on television for screening for this. They'll put you in a whole body CAT scanner, and that is a bad idea. Because when you get to be, I would say, over 45, there is no such thing as a normal X-ray or CAT scan of anything. And now that older people have access to their healthcare records through portals, you see frightening things, a degenerative arthritis in the knees and the hips, and the brain is shrunken. And these things have very little relevance to function. You also pick up things like a cyst or a nodule that really does not need intervention, and it creates enormous anxiety. One of the great quandaries now in aging is not whether to screen, it's when to stop screening. So you're 85 and you've had a number of normal colonoscopies with no family history, for example. The risk of an additional colonoscopy and the benefit you gain is so trivial that should stop probably. The idea that everybody with this cholesterol should get this medication, like a cookbook, is crazy to me. If you've made it to 90 with an elevated cholesterol and no healthcare problems, I would say, woodsman, spare this tree. I just think it's, and so this is the art of medicine, that knowing people, what their goals are, the pill burden, the cost. The other saying we have in geriatrics is, in medicine, it's easy to do. It's knowing when not to do.
Yes.
And everybody has health insurance. It's called Medicare. So it doesn't cost me anything to send you for all these x-rays. and to thoughtfully explain to a patient, someone who comes in, say, for a headache, which I'm sure is a migraine, why you don't need an MRI for that is takes time, but it's the right thing to do. And it saves money for the healthcare system when someone who has a brain tumor needs an MRI. You know what I'm saying? So
Absolutely.
yeah, so it's really it's about communication, and it's about not supersizing everything. We live in a culture, Kathleen, where for Americans you get the bigger meal at McDonald's, you get the bigger room at the Hilton, and bigger is always better. Bigger is not always better as you age. More can be less. More can be dangerous, right? More subspecialists. We can talk about that in the same vein. Having 9 doctors prescribing different things, not
No.
communicating with your primary care doctor. That's the other question for a primary care physician. What are you able to handle in office? I saw a patient on Tuesday with atrial fibrillation that I care for. About a quarter of my practice is atrial fibrillation, a rhythm disturbance that's well
Right.
known. And shouldn't I be seeing a cardiologist annually? The answer is no. I can take care of that. Why would you want to schlep over there and get a different opinion and then me not communicate with them? If I need him or her, I will send you.
I absolutely agree with that. And I want to also say this goes back to the responsibility of the patient. So all of the listeners that are listening to what Dr. Lachs is saying, pay attention to understanding you don't want to spend your life going from doctor to doctor to doctor and visit to visit to visit. No older adult finds a lot of joy in that, except for hypochondriacs, who I don't think listen to this podcast. And so take some responsibility and understand when you're prioritizing your concerns and your questions, also understand it's okay not to chase every last test. It may not give you that benefit. Everything is a cost benefit. Do you want to spend that time going to the doctor? Do you want to get more tests and more specialists? That's not necessarily going to improve the quality of your life.
Yeah, no, I absolutely agree. And I would close by saying you want to meet the most important primary care provider, look in the mirror.
Yeah.
Look in the mirror. If you think you can just lie supine and the healthcare system is going to take care of you, okay, and everything's going to be okay, you're making an enormous mistake. You have to participate in your care and partner with your primary care physician, okay? You need to know what your medications are. You need to know what your most recent lab tests are. Your x-rays belong to you, okay? Everybody thinks the electronic medical record is going to fix everything. Well, if they take it to the other hospital in your community because you fell and broke a bone, they're not going to have your medical record and know what your medications are. And that's if you can articulate what they are because you're conscious. So you need to take some responsibility for your healthcare. The healthcare system has become more complex than ever. And I like the way you started this, Kathleen, which is that older adults are complex and the healthcare system is complex. Okay. And two complex colliding worlds makes for potential problems, but you can mitigate that. And this has been such a thoughtful interview, and I hope your audience got something from it.
I think it's been fantastic. I really appreciate you spending the time. I recommend the book to everyone because it does provide a lot of good detail and kind of a roadmap to how to navigate this complex system. Thank you so much for joining us today, Dr. Lachs. Thank you so much for joining us today, Dr. Lachs. I really appreciate your time, and I hope that everyone takes this advice. Thank you so much for joining us. That's our show for today. If you liked it, please give us a heart, a like, or subscribe on your social media. And until next time, enjoy the chance to get smarter about growing older. That's our show for today. If you liked it, please tell your friends so we can reach more minds and keep the conversation going. Or follow us on social at Seniority Authority. I'm Kathleen Toomey. Until next time, enjoy your chance to get smarter about growing older.